Now, look at this one and compare it to that one. Two different people, but I had a nice clear diaphragm here, not so clear over here. You see that?
Mm-hmm.
And this seems to be an awful lot over here, not as much over here like it should be. It looks kind of like the heart's moved, doesn't it? And the heart moved toward this area where we can't see the diaphragm very clearly. Now, what's hard to see if you're looking straight at it, it's a lot easier if you look at it from the side. There's a border going up right there. Okay. Come and look over here, you can really see it. You see it? There's a border right up there. It's not as easy to see it looking straight at it. But can you see it from the side? Yep. Yeah. That border is that. Now, look at that lateral and compare it to this lateral. Is there a big area of white density on that one? Behind, above the posterior diaphragm? No. There's a border here, which should be here. That's the major fissure. And again, we've got a gradient density because the lower half is going back parallel to the beam. The upper half's kind of coming down like this. Very similar to the way we saw this over here as a gradient density because the beam's not perfectly parallel to it. So we're coming down, major fissures going back, the lower half's going back. So we've got this triangular shaped wedge of density. Remember, the fissures do that, and it also slides in toward the mediastinum. It's three-dimensional, remember? So it went back, back, and this way. And that density that we can see right there is the lateral edge of this. So what collapsed?
Lower lobe.
Left lower lobe. Left lower lobe collapsed. Patients over 40, the working diagnosis is endobronchial tumor until somebody says, no, it's not. That's the working diagnosis. Why? As we'll see next quarter, resorption atelectasis is the #1 sign of bronchogenic carcinoma. Endobronchial tumor is the #1 sign associated. Atelectasis, #1 sign, and typically bronchogenic carcinomas are over the age of 40. Now, it could also be asthma, it could be foreign object, it could be large lymph nodes crushing a bronchus, but it's most likely endobronchial tumor. So the working diagnosis is tumor until the pathologist says, nope, it's this that's doing it. That's a lower lobe collapse. And probably not quite 100% yet, but getting awfully close. And so what has moved? Well, mediastinum's moved, the diaphragm's probably come up a little bit, and of course the entire left upper lobe overinflates. And if there's been much movement here and over here, even the entire right lung can overinflate a little bit. Because when the mediastinum starts moving, something's got to compensate on the other side also. And so the entire lung on the other side can overinflate. And all it's trying to do is replace the volume that's been lost. Because you can't collapse it and have a vacuum where the lung was supposed to be. It just won't work like that. So all these have been resorption atelectasis examples. Now let's look at